a veteran who suffered spinal cord injury in a wheelchair, needing food, but they very quickly realized the need for mental health support. And so the funding we gave them allowed them to establish a mental health team in their food pantry. So mothers who have had, stillbirth, who are reeling from that, they're coming for food, but then we realize they need other services, and we were able to see what our funding support and the vital connection using community assets. So I want to say thank you to you for your leadership, for challenging us, for encouraging us to be more in tune with the community. And I want to say that we appreciate your advice and feedback. We talked at length about funding and prioritization. We talked a lot about vaccines and how we were prioritizing. We're very fortunate to get additional resources. And now, as I last week, the report from the team, we've seen a 27% increase in vaccination this year relative to last year. So, again, saying that your input, your feedback is what will continue to be open to that information. Budget is something that you've been very worried about. So the city's budget has finally been approved. We've been very eager for that. We don't yet have the final numbers in terms of where we land. So we hope that in January we'll be able to tell you the specifics. Our grants, you all know, we've been in close conversation with you about the scale down. So we had an executive team retreat this week to plan. And over the next 2 years, all of the COVID funding, one-time COVID funding we have will expire. So we have been thinking through what our core work will be, what we'll need to change, how we'll need to adapt going forward, and where there might be opportunities for us to mobilize resources. So one of the things we're exploring is the opportunity of setting up a foundation, similar to other big cities and similar to the Chicago Public Library. So we have received about $1 million from the MacArthur Foundation to the United Way to help us explore that opportunity. We will continue to explore public-private partnership, but what has become evident is the need for us to be in closer partnership with the community. And that is going to be the winning strategy going forward, how we partner with our health systems, how we partner with our academic institutions, and we partner with our community institutions. So that is the recap of the year, what we have accomplished, and how we plan to go forward into 2025. Next slide, we talked to you about our strategic plan for 2025 because of the progress report we saw in our life expectancy journey, that we were not making as much progress as we had anticipated. So we had to go back to the drawing board. Continuous improvement is something that we are committed to do. So what we have found is that the gap between Black and non-Black Chicagoans is widening, and you gave us some feedback there. Pilot in 5 communities, and they use the lessons learned there to scale up. So we are going to do this pilot for 1 year. Our focus here is on health equity, and again, your constant feedback, collaboration. We cannot do this alone. And then centering the data and using data to drive our approaches. So chronic disease, violence prevention, substance use, infectious disease, infant and maternal mortality, mental health, and partnership are the core areas of focus. What is going to be different is instead of one disease at a time, we want to bundle our programs in particular so that all teams, all programs, we are synergizing instead of one person, going out for lead and another person going out for vaccination. Is there a way for us to use our resources better? Our priority population, of course, will be Black Chicagoans, but communities that have the lowest life expectancy, but also going through a decline. It's not that the life expectancy is the lowest, but that it is getting lower. So there are 5 communities like that fit into that bucket that we will be focusing on. And we will continue to share progress next year totally challenged us to have a plan and then give us updates on the plan. That's what we're gonna do. Now have a plan, share with progress and we need to hold something over it. So that this strategic plan was posted yesterday for public comments. It will be open for public comment for the next 3 weeks, and then we'll finalize what our teams have already started. Part of that plan is this seasonal vaccination drive. We already started to review that, so we'll come back to with the mid-season update next year. Next slide. So I will pause there before we go.
Any comments from the board and also for those that are online?
Always asking. So you talked about the plan and the funding, and you connect that to the foundation. How does that work? Are you trying to say from private companies, donations that you can then use for this plan, and will that affect how the city funds come to you? Because sometimes it's a rock Peter to pay Paul. And so I wonder how the foundation disconnected enough so that it doesn't affect, you won't lose funding that you have already. It'll be an addition to that.
So the three major sources of funding we have right now, federal dollars through grants. Those grants are mostly always just focused on local health departments. Those are the grants that we go for, grants that are for community-based organization. Then the city dollars, you already know what we're getting from the city, that's not negotiable. And then the part of funding pool that we have already explored is the philanthropy of private donors. So the foundation allows us to tap into that. Typically, as a former executive in philanthropy will they will give money to 501c3 for their donors. So we are not a 501c3. So if there is a 501c3 that focus, will they be funded? So the initial part of this is to explore interest in this model so that we're not setting up something to fail. So there needs to be first an exploration of if this is a model that philanthropy would like to use, and if so, in what areas. So other cities in New York that have had this, they've been successful in leveraging philanthropic dollars. I also know that in places like Vegas, where the food industry and the entertainment industry is huge to support their permitting and all of that, they have that partnership to help fund some of their. So these are some of the areas we're exploring. How we're going to tap into this new pool.
One, I think let's keep it in foundation. I think it's really important to, as we think about current state and also historical, how are we able to diversify sources in order to make sure that programming? And I think that's, there are examples like you said. Interestingly enough, in looking at different states and or jurisdictions that have done this, one I think is really interesting is the state of Florida actually does this, and from a state as well as from a county. So I think exploring that would be very, very interesting. I know I've spoken to you, but there are interested potentials that could actually support some of that. So I think that's actually really great to hear that if you having your feet underway, being able to think about that and knowing what our, the city and the state's kind of circumstances may be moving forward would be really good, important. The other I actually wanted to comment in terms of your strategic plan is really that focus in terms of the holistic view of public health is so important. And I actually don't know if it was actually in alphabetical order or not, but if it was not, this is actually number one. I think it needs to be highlighted because it's so important. And it was in alphabetical order. I need it in order of priority. Actually, see undervalued in terms of the implications of
Reason why that is really a challenge for us is the funding that CDPH has right now, 70% of the funding we have is for infectious disease.
Yeah.
And if you look at infectious disease in terms of, you know, its contribution, it contributes 0.5, chronic disease is 4.7 years of life.
And that mirrors, I mean, national interest, international interest in funding. So I think really amplifying, from a city's level in terms of livelihood, that the importance of chronic disease, hopefully will actually help really kind of push the need, I think, which the implications of
So a little context to why we're sharing this with you. Part of our work this year is to look programmatically what are the primary drivers for mortality or health in Chicago. If we're responsible to keep people why they're not healthy and what we can do to solve it. So that's a strategic plan. But the other component of our work is how do we respond to requests from our residents. And so 311 is the primary portal for doing that. So we did an assessment this year to see how well we are doing, to set new goals, and then to identify inefficiencies and how we can improve. So we have our chief informaticists here, Akana, who will share with you what we have found this year and where we want to go for 2020.
Thank you. Good morning, everybody. So I'll start. So I don't think I have to explain 311 to anybody over here. You all know about it. But the goal set up going forward is 90%. So that took a little bit of work to get done. How do we handle it? Initially, we used to get an email, which is an Excel file for 2 years data of the 311 tickets, which are pending or damaged. So we were not able to assess how to understand it and what to do with it. So we reached out to OEMC. We understood it's the Salesforce platform. We kind of understood how it is broken up. There is something called a service request, a work order, breakdown of all of that. And the subject matter experts within each department is allocated this work and stuff like that. But the point is, this has not been revised for many years. People have gone in, but then it's not been revised and things like that. So I think we were the first department to ask them, saying that we need to acquire this data. We still don't have an automated process. Shri, our data scientist, actually pulls in data every morning to update our Tableau dashboard. So Tableau, because the city has said that we have enterprise licenses, we don't have to spend on it. So we went into Tableau, and now we use Tableau now to extract all the data every morning. We did have to go a little bit back and forth to get all that information, stuff like that with OEMC. They have been an awesome team. And let's go to the next slide. So basically, the whole journey that we showed you, we started off with data we received for end of 23, talking about 85% resolution rate. And now with the visibility of the data that we have, and follow up with the supervisors and the SMEs to ensure that these tickets are resolved in time. We have SLAs, basically the timeline in which we have to submit these tickets. All that was done. What we're doing right now is basically trying to understand if there is a delay in resolving the tickets, what could be the reason. So I will walk through that shortly. But what we have done now is to be able to get the problem statement in front of our leadership to understand and resolve these problems. That's how we went from what we saw when we started this program to where we are today, from 85 to 88%. So let's go to the dashboard.
Here, if you just see the common request that we provide. So it's interesting for you to know that restaurant complaints, noise complaints are what residents of Chicago are most worried about, not anything. So thousands, this year, more than 8. But mostly restaurant equipment, air pollution, construction, those are the things that go to us. But
just a question is looking at groceries. What does groceries mean? Is it a food security issue, or is there
these are where their attention, when people go grocery, food is spoiled, all of that, they come to us, but by ordinance, we don't have control over those things.
Yes.
And these are some of the things that we're not able to resolve because we really don't have any authority in those spaces and people don't understand.
So it's not a food insecurity,
Right.
it's like food quality at the restaurant, food quality at the.
In our space, if there's area.
So it's time to err.
But there's another step. There is also the intake questions. We are evaluating all the intake questions and how they are resulting into the resolution, because if there is a lot of explanatory sections, sometimes you don't know what is there. There are a lot of tickets that come to us which are not for us, like water, for example, lead. Lead gets a lot of water-related stuff which is not for us. So we are trying to look at the description of each service request, look at that, even look at the intake questions, and in case the first level could not resolve the, confusion, and then how do we do it at the second level so that, we can try and ensure that the right department is getting the right advice.
And actually, if I may, so we see what 311 routes to CDPH here. So there are probably innumerate calls for housing,
Yes.
those are going to, so this,
Yes.
the mental health calls. We don't get, where are they going? Is it DH? There goes,
should say,
Well, and also two.
that's right.
Two.
We don't get it. They call, not people coming to us to say that we are trying. So there's 211, there's 311, there's 9. Through 911, there's right. 911 also, we assume that they are calling in. The numbers are very low. People calling for behavioral cases. Numbers are very low, relative to the thousands that we get from. I think mental health.
Okay.
So just to answer, to represent this to OPMC, they are using our support our requirements. So this tableau is being shared, right? I think the FSS is working on shelter. Yeah. So basically, we are trying to help them. We've shared all of the things that we've learned in Tableau, the enterprise solution. So that's where we are today. Go to the dashboard. Yeah, thank you. So if you look at this is just getting the problem statement legible, easier to resolve the problems. That's what we've done. So this is a Tableau dashboard, and this is okay. Okay, that's fine. So basically here we have the summary of all the bureaus we have, how we do it, and how each SME is allocated this work. So we have sorting everywhere. Like, so we really don't, suppose it's just for what particular program, they can sort based on what program they're on. They can just see their numbers, and they can go back and see what resolution they have to do. If they cannot, then how do they address it and stuff like that. This is just to address problem statement. So going to the next tab, these are the types of service requests we get. So as she said, the restaurant complaint. Just
Data informs more than just performance management, how well, how quickly, but also helps us to allocate resources. If restaurants is the biggest thing that Chicago's need help with. And if people are saying that there's a food safety concern, we don't have the luxury of waiting 41 days to respond to it. So how do we allocate our staff? And these are some of the data that we're using to plan for next year. If we have limited resources, what should we prioritize? This is part of the input into that. What is it that people are asking us for? How do we prioritize these issues?
Can I ask, what were you most surprised when you actually saw this data?
Equipment noise.
Yeah.
And this is also another area exploring. People come to us with equipment. This we have jurisdiction for machine noise between 8 p.m. and 3 a.m. If it is in during the day, we are not able to respond to it. And if it's in residential quarters, we're not able to. So these are gray areas where people keep asking. We get a lot of questions about noise. In residential areas, we don't have jurisdiction. We don't have authority. So many times others will call me and say, oh, there's this gym in this building. I want you to do something. I said, I don't have authority to be able to do those things. So there are some areas where there might be opportunities for us who should be responsible. Or when people say, we have food trucks or food vendors, and one of them said, yes, we have some, but again, given that we have only 32 inspectors to process thousands of permits, and you're going to hear more about that, and you see the continuum, how do we prioritize? What can we respond to at what time, given the very limited staffing that we have?
That's another question.
Yeah.
Who assigned that these actually go to CDPH? And what are the other kinds of? How do you know that they're misassigned to another department?
Right, just go to the redirected ones. So it's like there is a lot of discrepancies we've discovered during the process. One is the intake process, and the second thing, there are 3 levels at which you can actually report a 311 request. One is a phone call, the other one is a website and an app. The website and the app do not have like 7 of the service requests that are supposed to come to us, so they can only come through a phone call. So we are fixing that as well. We're talking to them and telling them the website doesn't have these categories of service requests, nor does the app. So, but and then we have to give the reading points to the call center people as well. So there was a discrepancy of that as well, because we were seeing service requests, and what my thing was, how does a user use it? So I was like telling them, like the ACA rules, use 7th grade level of reading and make sure that it's easy for somebody to understand what it is, because some is complicated abbreviations are all will not like people understand.
But beyond, who's making the decision that
This is
restaurant
OEMC.
is it's the OMC is making that decision?
Yes.
Go to
What is assigned to different departments, and that's one of the things that we do. What is coming to us that should be a lot of time trying to find when you should go to. So that needs to be automated and responded quickly.
Yeah.
And then what is supposed to come to us and is not coming to us.
Exactly.
So that's also another thing that.
And these are the redirected ones, assuming that we get a ticket and we think that we know it's not ours, we want to direct it to a different department. The system was set up in a way that we are accountable for the other department to close that ticket when we have no jurisdiction. So if you see these 2 departments are now being tagged for these number of tickets instead of the responsible department. So we have spoken to them. We're also working. That's also a thing we have raised for them to change the system workflow so that if a redirection is done, it's moved to the other department. But there's a bigger story to it where we are going to need help OEMC do it. Like how many times, like suppose they bring it back to us and back and forth, when do we get the remediation point? Like, of any ticket or things like that. We are talking in those terms and we will try resolving for OEMC as well.
Right. But that's downstream. I am actually really thinking about in terms of from a design standpoint. It doesn't like the fact that it goes to 2 people. Honestly, from our perspective, we shouldn't care. We need to know that it's the right ticket or complaint is going to the right department. And the job is not about, you're defining the process of how you're rectifying it, but there is something much more important to be done upstream.
Am I interpreting the total number of work orders, the number of work orders redirected correctly, that, 1/3 of the work orders that come to the department actually need to go someplace else?
So you need to go to the department.
Yes.
That's,
Those are the inefficiencies.
that's waste.
Right. That's why we want to be responsive, and we cannot be responsive if we're spending a third of our time on things that are ours. Right. So this is our commitment to continuous improvement management. First, if just even being able to visualize the data and see where are the inefficiencies in our processes and where are we spending time that we shouldn't be. And part of that is now at a systems level, how can that algorithm or assignment be fixed? But it started with us taking a look at how we were performing in our bureaus. And once we saw that we have outstanding tickets, 100 days, 200 days, then I'm asking like, why is this taking so long? And then it's like, there's a laundry list of all the issues that we have been trying to solve. So this is sort of like the process improvement thing, how can we be more responsive to Chicagoans? But we realize that even the systems need to be fixed to make us more responsive.
So one thing we learned is when we had this conversation, multiple conversations with AMC, they said nobody came to us with the kind of questions you're asking us. So they were ready to, look at it and all that stuff. So I guess, yeah, they're working with us and they want to replicate with other departments, but they also don't want to see these. That's basically, there's one more, we have open SRs tab. That's basically, this is for all the SMEs to look at, and a mail is going out currently on a weekly basis. So SMEs to make sure that they resolve this. So
now at a glance, I can see weekly what is outstanding. All the deputies can see weekly what is outstanding. We have a commitment to respond within the time frame. If something is should be responded to within 21 days, it flags red once it's past due. So it makes it easy for us to stay on top of our work. So this is again part of our performance management. We have clear plans for the health outcomes we're going to change. The second component of that is being responsive to our service requests. And then the third component of that is making sure that all the mandatory functions that we're staying on top of it. That's why, we'll have some of our regulatory folks come and talk to you now so that you have a picture of what we're doing in some of those spaces. So that you have a full picture of our plan to 2025, health equity goal, service request goal, regulatory function goal, and then something.
Super informative.
Yeah.
It's so much difference between 3 and 20. Do you think the 3% difference is big because at first glance, it doesn't look that great, but is that 3% change significant in your eyes?
Yes. Again, given that is 8,000 plus requests per year, 3% is significant. And given that we now have at least 134 positions less than what we had last year, 3% is even more. So yeah, and that's why it's important for us to fix all of the inefficiencies in the system if we're going to be that we have less to do more work. So we have to be precise in what we're focusing on if we're going to make any.
and once the systemic issues are fixed, you will see a very different number out there. Because there's a lot of dependencies in other departments closing tickets and all this stuff. So that will go, and next time we fix it, numbers.
Let me ask my usual basic question. Say, so how many Chicagoans do you think, because the first question we asked was, I know 911, I know, but how many Chicagoans do you know to call that? I mean, what's your confidence they do know to call it? Because like at our church, we don't get certain calls. I can tell it means that people have either lost confidence in the department, don't expect to be heard. They don't call, and we say, well, there's not a need. Well, there is a need, but they don't have an index of trust with you. So I wonder how many Chicagoans are, you need more advertising to say, look, if this is having call this number versus the other, because I wonder about that.
Yeah, I think you're right. Awareness is one thing. You talk about trust a lot. Part of that is being trustworthy.
Yeah.
We want people to know that when they reach out to us, we will respond. So that's making sure we're trustworthy so that when we go to people and say, call us, they know the call doesn't go into an abyss. And that means that we have to do some housekeeping and make sure that when people do call CDPH, we will respond in time. So we want to start with this housekeeping and then make some noise and say, if you call us, we can guarantee you we will respond. So we make ourselves trustworthy and then we start building the relationship. They call us and we respond.
However, 311 is for all non-emergent services.
Oh,
So I mean, you say that, however, any other department may not have the same.
Exactly.
You're not building the trust. And my other question is, maybe 911 probably much more, 311 probably will be on by now. Two. We can turn the numbers or the word of recall, the more complex, and then I think the use and
So our next phase is 912. Especially in the places. We've completed that assessment, so we could bring it to you and tell you what we have found. We're not getting a lot of calls from plan care team. So we look through, see is that where it's going, is not that where it's going, is it going to 211, is that where it's going. But right now, if you call 988, if you call any of those numbers and you have behavioral crisis, it will still come to us. So we're like, we want to make sure that all of those numbers know to plug us in. But we are also exploring self-dispatch. If people are not calling those numbers and there are other ways we can and be responsive to them. So we are looking through all of those. The messaging is complex. The many numbers, people's awareness. But what we want to make sure is that we can meet needs that are available. People know to find us, have the staff and the functions to be able to respond. Now, the complexity of this is, the care team, we have started this, we're setting it up funded by Apple. So we need to figure out what sustainability would be, and then we start making some noise and say this is how it's going to be. Because if we do all this work, then in 1 year we have to sunset the program, then we so these are some of the complexities of public health grant funded initiatives. The ups and downs of it just makes it challenging.
Conducting a proper interview if we do it register.
sorry, Deborah, can you repeat? Deborah, we hear you, but you just broke up. I think other thing that we really is to think about where if they do have a remote emergency, like it's an emergency, and where they're actually being seen are more likely our emergency departments. I can actually probably attest to it.
Yeah.
They are they see it. Services are being provided in the modality. I mean, is it if someone's having it, last thing they're going to think about is to call. Someone else is calling. So I think that's one of those things to think about. I think it's really interesting that even though you have established, it would be very interesting to see the data that you're, all these calls are coming. I think to your point that you're alluding to, if the volume is not there, where should the kind of services be actually diverted and or reallocated?
Very connected conversation there. So we'll come to you with what we have found in terms of potential issues. The state is also funding 590 grantees, so they're experiencing the same dearth of engagement, and the hospitals are over on 5, 10, 20 hospitalizations for SMI a year. So it's a very complex dynamic that we need to solve for. All right, thank you.
Thank you.
This is a less same area of our work. It's significant. We haven't had a chance to share some updates there, and so we invited our oral health team to talk to you about what they do.
Thank you for having me. My name is Ann Tusher. I'm the director of the oral programs with Micah. With the oral health programs, we have 2 programs. We have a school-based dental, which I'll talk about first, and then we also have an oral health promotion program. First part is a school-based dental. We have a partnership between CDPH and CPS. And for all students that turn in a consent form, we provide access to preventive dental. We do not do restorations at all. And this is at no cost to families. We charge, the dental providers will bill the Medicaid, all kids, and if the family has private dental insurance. That's all. Nothing comes out of us. Next slide, please. Overview of the summary of the program. We provide dental prevention care to, they're actually at 522 schools now, CPS. And for the students that do turn in a signed down consent, their parents have to sign it, they will receive the services. And we have 12 dental providers, professionals, that'll come into the schools, they are assigned to schools, and they will provide dental exams, screenings. The children will have cleanings, we will do sealants, and also fluoride varnishes. And since the program began, fun fact, since 2000, 1.3 million children have received dental care with us, and nearly 3 million sealants have been placed on these teeth. Sealants are a little thin coating that we place on the back teeth, so a cavity cannot get in. We fill in all the little tiny grooves. They're excellent. We go to the next slide, please. Students that do need to have additional care, which are a code 2 or 3 cavities. And what we do is a case management. They have these dental providers, we'll call the families. And we do have an extra step, and we're trying a new program too. We have a pilot. We work with Oral Health Forum. Oral Health Forum is fantastic. This is a group that when you call family, say, okay, you have a dental problem, you can go to this brick and mortar dental facility in your zip code to have care. You can go to them. Also, is there anyone else in your house? Someone may have diabetes. You can go to this center. They do those extra steps. They will make sure that you have a ride there. They will make sure that you do have a provider that you can go and see. They are fantastic. So what we're doing, which you'll see in the next few slides, we have schools that have a very high decay rate but have a low turnout. So what we want to do, we're starting a pilot program with several schools. We can go to the next. And another one fellow. But you can see we did lose, this is just over the years, you can see how the program had gone down. And you can see, of course, where COVID is. We were looking at the data and we've been talking to facilities. Why did we lose so many student participation? And years ago, they used to have dual billing, which you can see your dentist office and you can see the school dentist. They had stopped that several years ago. And that's when you had dental providers, well, we can't see you if you see your school dentist. I think that's when the dip started coming in. With COVID, HFS had brought back dual billing. So now it's getting that word back out that yes, you can see your school dentist. Yes, you can go to your dentist. It will be covered. So we're trying to introduce that back into the families. So we're letting the schools know about it to send that information out. Next slide. And this is where that one pilot program will come into hand. We took all the decay rates and we placed it into the zip codes on the map. You can see where 660 has a very high decay. There's a very low turnout of students also. So we're taking these schools, we're using Oral Health Forum, we're doing an incentive. Where for families, they will actually follow through, get the dental work complete. They will receive a CDPH cooler bag and everyone in the household will receive an oral health kit, which would be toothpaste, floss, and toothpaste, toothbrushes. So we are trying to get everyone to a dental home. This is what our final goal of the program is. You want everyone to have a home to go to if there is a problem. So you can see over the years, just trying to get everyone to participate. It's also. So we also have a new equity focus. Another pilot program with CPS to encourage the participation into the dental program. High rate of decay with a low enrollment. And we are working with CPS schools. And with the CPS schools, we're letting the administrators know there's a problem. We have to address the problem. Your students have high rate of decay, so we are getting them involved also. What can you do to help us to promote the program? to get the more students. Incentives are, it could be an extra time at jam. CPS is for the younger ones, it could be a little gadget calculator. But we are trying to work with them. And if there are any ideas, we're always welcome to ideas. And so we have pilot schools in this program with Carter, Dulles, Bradwell, and Walls High School. Those are the highest ones. Decay, the lowest turnout. Any questions on that school base? Decay rate for every student that comes through the Oracle within the city, we upload the data. So we have a code 2, which is a 5 and under locations of teeth. Code 3 is 3 or more of low out of the tooth. 5 or more cavities, the abscess tooth. And we keep track of all that. So we know if we go into a school, there's 100 students that we see, 20 of them are code 2s, 10 are 3. So we just take the percentages. So we keep track of all that.
But you don't know really what the denominator is. I mean, you know, it's basically an opportunistic number. It's not
Right,
necessarily.
it's a convenience.
It's a convenience, exactly.
So it's based on those who are participating, if you know, 100 children participating, but 20 of those have put 3 or put 4, that is a high percentage.
But what's the population of the student?
We have the student population of the school. To your question, we do have that. And we are working with CPS on that for pilot schools. I want to know, to put the whole puzzle piece together, how many students actually turned in a dental form already?
Exactly.
Who has their own dentist? So that is the pilot we want to know. So I'll have a summary at the end of the year, after the schools have been seen, how many actually are we reaching? And that's a question. We want to make sure that everyone is being taken care of.
That's the question is,
Yes.
is what percentage of students in CPS access this? Because, you know, physicals are required,
Yes,
but dental, I mean, it's not.
Right.
And I'll bet you that the percentage is much, much, much lower.
this is the students. These are actually the students in the school that participate in the dental. So we are in
Where's the total
CPS.
for students in this?
Oh, we have that, yeah,
See,
that
that's-
60%, 50%.
Yeah, the issue is how many students you have total in the CPS schools. Then you can say 10% participated, 50% or whatever. If you don't know that, it's hard to know who you're impacting. Because, you know, the kids on our church, I'll guarantee you half of them have cavities. And I bet they're not saying, this is a screening program, but they're not being picked up early.
Well, it was doing a calculation, so 1.3 million children over the past 24 years. That's an average of 54,000 students a year. What's the total enrollment of CPS? I mean, that's a very, it's a tiny, tiny
I'm gonna
fraction. So
say
you're
it's small.
saying pay rate is, you know, something.
And yet these are probably in many ways the most vulnerable, I mean, right, because they don't already have a dentist, you know, we don't know that. Well, most of these do not. So. But the hotspots are probably the hotspots.
This mirrors everything else we are saying. You see, it is the thing. Preventive care and uptake of preventive care, whether it's vaccines or preventive oral care or lead prevention. We see the same pattern in the same neighborhoods where people are just struggling to stay alive. And that the premise or the assumption that because services are not available is why is not always true. That sometimes when services are available, take of those services are low. That's what we're trying to explore. What is the best way to increase engagement in services that are in on the west side and the south side, and we see this consistent for every preventive program.
South and west side.
That's why, and, you know, communication awareness, I always harp on this. If you don't do that, anything else that you do is gonna be minuscule.
Right.
Cause you're missing them. You're getting kids with, you know, at 7 or 8, got 8 cavities. If those kids had been picked up early on, you wouldn't have that issue, but and I guess a part of it is just like you said, people are just trying to survive. You know, dental care is not very important to them until it gets to be a problem that keeps them out of school or whatever. That's down.
So we continue to need your
Yeah.
input. How do we
How do
engage?
we-
Family Connect, we actually go to homes. And from then it's only 20%, 30% uptake. People say no, thank you. So that's us going into people's doing community outreach, doing work, doing local engagement, doing door-to-door nothing. So if from your own expertise of being on the ground, we're open, what else can we do to engage people? But uptake of services regard is just not.
Part two of our program, we have the oral health. This is a PH. And with this, we partner with six CDPH WIC and also 5 delegated patients. We, several community agencies, one is Stork's Nest, we go into Carroll Road Center. And what we do, we promote oral health care for pre and postnatal care and early child care. We work with them. We bring oral health supplies and education. We do the oral dental kits, we do tippy cups, we promote nutrition, coloring books, and just overall. We have it in 12 languages. We also have flip charts. So as we're talking to the families, as the WIC staff is in there, they can go through the flip chart for how to care for a child. It's in Spanish and English. So as you're showing the pictures, you can read it to them. It is an actual great program that we do have. And you can see over the years, it has been increasing. So far for the first quarter, we're at 26 families we've reached so far. So yes, excellent. Thanks. And then we do collaborate with other areas during the summer. We partnered with LED at Gately Stadium. We reached over 100 families. And so we are going out into community and just trying to reach out.
Hi everyone, good morning. This is a great information to have. Thank you for sharing. I wonder if you could, I know there are quite a few dental programs. One that comes to mind is like Mobile Care Chicago, where they're in the schools also providing these type of services. And I wonder if there is a data or information on how this work is helping to address what the need is. And there may be even more that are working on this. So I wonder if there's more of a systematic picture of the entirety of these type of oral health services in schools.
For the mobile care, we do not have oversight. We only have the data for the schools that we do see. CPS is in control of who are the other providers that go in. We do quality assurance assessments of all of our dental providers, everyone who goes into the school. We go out and do make sure they're doing the proper PPE. We do clinical exams on students to make sure that the sealants are there. We do make sure that all the calculus is removed. That is what we do in our program. They are not under care. That is a CPS.
There might be opportunity with understanding the scope of the service citywide, knowing their contribution to this effort as well.
That is something we can look into. Yes, we can look into doing that. We would have to reach out to them and they would have to be willing to give us all the data. Yes. Any other questions? Okay, thank you.
Public health. You can go to the next slide. Wanted to start to recap the forecast in terms of public policy and some hot public health issues. So just as a refresher, at the city level, our budget has now, as Dr. Ede said, which we're analyzing. We'll provide updates when we have them in the new year. City council meets year round. We move to the state. We are anticipating a very short duck session right after the new year. shortly after that, the next General Assembly will be inaugurated. So that effectively restarts the legislative process. If it's not concluded during lame duck, we restart the legislative process. We anticipate governor's budget address in mid-February. Spring session adjourns in May, and then it'll be up to the legislature whether they do a veto session later in the year. And then at the federal level, we've talked quite a bit about the continuing resolution that the federal government is operating under. It is now time to pass a new continuing resolution. Legislators are debating that and hoping to get something done before December 20th, which is right after the new year will be the inauguration of the new Congress. So same thing, right? So we would like anything that is not passed, we start the legislative process over, inauguration of a new administration mid-January. And then as we discussed, theoretically, the budget process starts in the spring and the fiscal year ends. September. We know that this is not likely to be a typical budget year. And then I'll also note, just as we're thinking ahead in public policy, anytime you have new legislatures and anytime you have new administration, typically the first 100 days are the most momentous for policy making. So we anticipate, I guess I share that, we anticipate this year, given the policy opportunity which we will be working and the interplay of where there will be opportunities that change depending on the city thing. So then if we go to the next slide, we have started to work with our national partners, state partners at the city level first to really forecast what we think are going to be some of the public health policy issues. And this is a conversation that will continue in the new year. So, give you even more detailed analysis here. But we talked a lot about public health infrastructure. Again, I just want to name there are some really important conversations happening at the federal level about what is the scope of public health. So I heard us here today the importance as a driver locally, and yet we are having conversations at the federal level about should the Centers for Disease Control engage even in chronic disease activities or injury prevention activities, so which is another key expectancy gap. We have talked, quite a bit about the funding and workforce advocacy that we must continue to do at the federal level, given the makeup of our budget. If we move into health protection, we talked a little bit last board meeting about vaccination, access to vaccine, particularly a vaccine for adults. There's already a vaccine for children's program. We're watching adults, thinking critically about how we can defend, but where we might be able to enhance. We expect a very substantive and lively conversation about food and nutrition standards. Some in public health optimistic that there may be more opportunities for things like food as medicine. Others in public health are a little concerned about be going here. So, in the new year. And then maternal and child health. Certainly we've talked about reproductive health, access to healthcare for birthing people, families. But I also want to watch paid leave together in the upcoming year. Paid leave, I will just, the optimist in me want to say something hopeful. Paid leave did very well as in other states in the election, and paid leave can be a bipartisan issue. So I'm going to have a little hope that there could be some generative momentum in the paid leave in the upcoming year. And then in the substance use and overdose prevention, first we're looking at access to our overdose antagonists, but then really a lot of conversation. There's legislation that's been introduced at the city level. So Pittsburgh also weighing in additional regulatory frameworks that you'd like to see back from the state. We're watching to see that this is something that's going to continue in the year. I know that's quick, but I would love to hear if there's other big public health issues that you all are looking at or watching, and I'm glad to answer any questions.
Yeah, I mean, the access to vaccinations for me is it's the great unknown here, right? Because, if the VFC program were to be significantly dismantled, the impact old enough to, I'm not even sure, between the two of us, remember iron lungs, what, from polio,
I mean,
yeah.
Yeah, they never saw.
Right. I mean, I got trained in the hospital. We had iron lungs in the hallway. We saw people who were readmitted, and especially the questioning of the polio vaccine. So I don't know. City or the state have the resources to.
Regarding the VFC program, so it is an entitlement.
That only CDPH can do. There are no partners, there are no by law, a public health must do. So it's important that we get it right.
Hi, good morning. I'm Virginia Castañeda. Just quickly about myself, I've been with the CDPH for 23 years. So just so you know, I started as a sanitarian. So I actually did the field work for about 5 years. Then as a supervising sanitarian for about 5 years, and then about 10 years chief sanitarian. And now for about 3 years, Maribel gave me the opportunity to be the manager of the program.
Maribel Travis Torres, I'm the Deputy Commissioner for Health Protection, been with the Health Department for 26 years. Started with the immunization program, was the vaccination coordinator back when I started, and became the program director for 12 years, and getting the opportunity to lead the Health Protection Bureau in 2016. I have a great team. I'm holding us rather large, but today we are focusing, on leading the food protection. We've got my group, say food emergency preparedness, inspection, immunization program, the operation side of the house. So I'm going to turn it over to Jeff. Next slide.
So these are the highlights for what we're gonna review today, who we are, what we do, our accomplishments for this year, our challenges, and our 2025 initiatives. So just our funding source, our corporate funding source is about 5 million. That's covers personnel, and grants is 1.6 million. So we have 10 staff members that are under local health protection grant, one under emergency preparedness, and one under tobacco grant. Next slide. So sorry for the small boxes, but this is so we have 66 full-time employees. Right now we have 54 filled positions and 12 vacancies. Out of those 12, we have 6 vacant seats for sanitarians, 4 for supervising sanitarians, and recently 2 senior data entry operators retired in November. So that's how we have 12 vacancies. Our funding source is 54 for corporate and 12 for grants. Just quickly, so we have 5 districts that covers the city. Each supervisor has their sanitarian team. And right now we have 38 sanitarians in the field. So what do? We are committed to the safety of food in the city of Chicago. So this is why I love my job, because my program impacts the entire city of Chicago, not just a specific population, even tourists that come into Chicago, because everyone has to eat. So we promote public health in the areas of food safety and sanitation to prevent the spread of foodborne diseases. We educate operators, we address food-related emergencies, we enforce the municipal code and use our food code rules, also to ensure that the operators meet the minimum requirements in Chicago. So these are the types of inspections. I know sometimes people say, oh, they just do inspections, but we do different kinds of inspections. So the routine are the unannounced inspections when we show up at a facility and conduct our routine inspection. Our complaint, I know earlier they talked about complaints, so these come through 311, which they either enter it online or they call 311. They file a complaint about a business, not just because they file a complaint doesn't necessarily mean it's a true complaint, but we have to investigate those. Suspect food poisoning, when someone alleges that they became sick from eating at a food establishment, or sometimes we have confirmed cases that we work with the communicable disease program, that we work in partnership to investigate those facilities where people became sick from. And we do the license inspections. Those are required so that businesses could operate in the city of Chicago. So we work closely with Business Affairs and Consumer Protection to do those license inspections and our re-inspection. So when a facility has a violation that we need to follow up on, we have to do a re-inspection to ensure they're in compliance. Okay, what do we inspect? Most people think we just do restaurants, okay? So we do bakeries, the grocery stores for food safety, at grocery stores, convenience stores, gas stations, anywhere where there's foods, shared kitchens, ghost kitchens. Do you guys know what a ghost kitchen is?
No.
Okay, so that's pretty much a kitchen where the public is not aware that it exists. So you may order food from a fast food restaurant and you think it's coming from that fast food restaurant, but it's a kitchen that all they cover the extra production because that restaurant cannot cover that extra production for those deliveries of the food. So we inspect ghost kitchens, commissaries, pop-ups. So pop-up is some high rises in downtown have a pop-up where they invite restaurants and that the people could eat from those pop-up restaurants. Daycares, the food part of the daycare, schools, CPS, we work closely with CPS in inspecting their schools and also the private schools, hospitals, nursing homes, golden diners. Do you guys know what a golden diner is? So we work also with Department of Family Support Services. So these are satellite locations in communities where they provide activities for senior citizens, and they also provide meals to senior citizens. So we have to inspect those. Stadiums, all the stadiums in Chicago where the, Bulls, Cubs, Sox, Bears. So we're in those facilities. When there's a game, we have to go and inspect it. After school summer feeding, these are the feeding sites. So when there's no school, we work with Chicago Park District. We inspect those feeding sites. They provide box lunches for children, or there's after school programs at some churches. So we have to ensure that that food is safe for the children to consume. And liquor establishments, that's for licenses. We have to do the license inspection for liquor establishments. Mobile food vehicles, there's three kinds. The preparers, the ones that actually prepare food on the truck. The dispensers, everything's prepackaged. They just dispense food from the truck. And the mobile prepared food vendors. So that's like the push carts where everything has to be prepackaged. And the special events, festivals such as Taste of Chicago, shared kitchen users, which we have to inspect them if they would like to participate in a special event. So these users don't actually have a restaurant, so they use commissaries, an approved facility where they prepare food for events, or they also prepare food for catering orders. Churches, the unlicensed one, because there's churches that have events in their community, so if they're going to provide food for the public, we have to go into the churches so that they get the special event permit to be able to provide food. And another type of event that we did this year is the DNC, which I have more information on that later on. So the results for our inspections are either they pass, they have a conditional pass, or a facility could fail. Pass is if there's no violations or core violations. Core are what we used to call the minor violations. Pass with conditions if they have a priority or a priority foundation violation that's corrected during the inspection. So an example for priority is no hot water, or they're blocking a hand sink, or something's wrong with the plumbing, and they're able to correct it during the inspection, it'll be a conditional pass. A fail, if they have a priority or priority foundation that cannot be corrected, then we have to follow up in either 2 or 5 days, depending on the type of violation. And then finally, we do license suspensions. So if there's an imminent health hazard at the facility or it's continued non-compliance, they have priority violations, we are able to suspend the business license. Next slide. Okay, so currently, after we do our inspection, we provide an inspection report to the business. So each inspector has their own portable printer and they provide the inspection report. And this by law has to be posted at the facility at the conclusion of the inspection. So if they have core violations or minor violations and they pass the inspection, they will get that summary report that says that they're in substantial compliance. If they have a priority or priority foundation that's either corrected or not corrected, they'll get this summary. And once they pass, they'll get that summary. So this lists some of the violations, and if it's COS, it was corrected on site. So those are the two that must be posted at a facility at the conclusion of the inspection. Next slide. So as I was stating, the types of violations priority, they have corrected immediately or in 2 days. These lead directly to foodborne illness. They must be corrected immediately. Priority foundation, they get 5 days. They could lead to a foodborne illness. And then the more minor violation, once they get 90 days, that's general sanitation, something's not clean, they get 90 days. So those are the 3 categories of violations. And then we also have the clean indoor air ordinance. So we also enforce the code if they have no smoking, if they don't have no smoking signs, we could issue a citation if they're smoking, if they have ashtrays. That's also what we enforce, but that's not classified as a critical, as our priority or serious. And priority violations, the cost for those are $500 each. Priority foundation are $250 each. We work with administrative hearings, so the operator has the opportunity to contest the violations if they go to court, or they're also to contest online with the hearing with the lawyer if they like, or they could prepay. So we give them an option to prepay. So that's notice is on the citation. Next slide. So these are pictures that the sanitarians send me. These are not from Google. So this is an example of a violation. So this is what they're finding. So one of the leading causes of foodborne illness is poor hygienic practices. So if the hand sink is blocked or clogged, we know they're not washing their hands. So this is a violation. This is a priority violation. So as you can see, this one's clogged. This one, they have groceries, and that one's blocked by equipment. So I just wanted to show you guys an example of a violation that our staff is finding in the field. Okay, so in 2023, our staff conducted 15,700 inspections, and as of November 30th, we're at 15,050. So the most of our inspections are routine inspections, but how we prioritize inspections first are license inspections, because we need to get businesses open. So those are priority for us. So right now for 2024, we've done about 2,000 of those, the green. Then the next priority, actually our top priority is a SFP. If someone calls they're sick, then we have to address that that day or the next morning. Then our license inspections, then our complaints, we do not answer, that's a 2025 initiative, but we are not able to answer every complaint that we get, like Dr. Eve was saying. So sometimes we get duplicate complaints. The person have a person trying to close those out, says this is duplicate. And a lot of that process is manual. Our systems don't interface. So that also kind of delays in us answering the complaint. So an inspector may get the assignment today, they complete it, but by the time someone closes it in 311, it might be in 2 weeks. Because we only had one person that did that, and actually they just retired. So we're actually trying to sort that work out with the rest of the staff that's remaining. So that's our challenge. Sometimes inspectors might be able to do it within a timely manner, but we don't have the staff to close it out in 311 because it's a manual process. And then we've done about 3,000 re-inspections for this year.
And the reason why this number is like that, but 36 sanitary. So if we were looking for resources or funding, these are priorities. We don't want businesses to close. They are food, safety threats. There is no delegation. There is nobody else who can do this. We must do this. So in terms of prioritizing and planning, people don't always see all the back end of public health and where resources need to go. And that's why we're making it visible. People get upset when we don't show up for every inspection because we're dealing with thousands. And these are not people that have opportunity to telework or take one day off.
Yes, even the routine, we further prioritize those. We have those categorized by risk 1, risk 2, risk 3. So we have to prioritize risk 1s, those restaurants that are doing full, they're cooking, cooling, they're doing a lot of handling of food. So those are our priority. And our risk 2s are like our fast food restaurants. And then risk 3, we haven't even touched some of those. That's like the prepackaged foods or the gas stations. We haven't been in some of those facilities for years.
Can I ask about that? Because I remember when that was introduced with those prepackaged. 40 years.
Any rule without enforcement, you know how that goes.
Yeah.
We enforce all of those things. So these are the tensions. There is nothing that I get more confident about from others than
The trend has been the same with failed percentages the last few years that I've tracked it. So it's about 25% of our facilities fail the initial inspection. So that's last year 27%. Now we're at 24%. So and 16% conditional pass because they're able to correct the violations during the inspection, and 60%.
And again, we're doing to ensure that people pass.
Yes.
We're not in business of shutting down businesses because employment and livelihood and all of those things are also social determinants of health. So, but educating people, because again, the places where people fail are in low income communities of color. So we just don't want to be shutting down businesses. We want to educate people, let people know why these things are important so that they can pass the inspection.
The inspectors don't just go and can make the decision on closing someone. So when the inspector finds an imminent health hazard or potential close up, they need to contact their supervisor. So the supervisor makes that determination, and then either they could fix it over the phone, and if not, then the supervisor, who's a licensed environmental health practitioner, they arrive on site. So once they make that determination that a license suspension is going to happen, then they contact the chief sanitarian. Hey, we found this. Okay, go ahead, close them. And if she's not available, then they call me. So we have a system in place so that people might think an inspector is just here to close. No, they're not. It takes a process for someone to get closed. So this is just the community inspection map. So this is the number of inspections for this year. As you can see, it's a little bit darker here, but that's where we have more food establishments, like near the downtown area. So that's why it's there. And these are the closed food establishments in the communities. So this is Armour Square, which includes part of Chinatown. So from when Maribel sent me and got it in maps, I'm like, oh, this gives me a visual. We might have to do more education there. So Chinatown, and this is the Westridge area where we have a little bit more close-ups than the rest of the city. And that's like the Devon Street area.
Is the map on the right absolute number of closures or percent?
Number of closures.
Because, you know, there's also, you know, more restaurants, you know.
Yes, yes.
It's a little tricky to kind of
Okay.
interpret.
Yes,
So even this dark red is 6 to 9.
yeah. Because we've only had 80 something for this year, close-ups.
Percent, like, prevalence actually.
Okay.
Speak, I mean, I think both of them.
Okay.
Absolutely.
Okay,
So it gives you a sense of scale.
okay, thank you. So we also work with the Department of Administrative Hearings. So when there's violations, we issue almost like a ticket book, like the police officers. So last year we issued 9,900 counts. This year up till November, we've issued 8,500 counts of violations. So total fines and cost imposed for 2023 was 3.1 million. And as of November, we're at $2,861,000 for fine and cost imposed for food protection. Next slide. So in addition to our regular year-round work, we also have to work on special events. So this is the peak season that we're like so busy. So we did reviews in the summer. These are how many licenses we approved. Multiple event license, just to make you aware, that's a license where a facility could participate in multiple events. A single event is just for that event. We inspected 26 events in the summer. This data does not include the DNC. I have a separate slide for that. These are just our regular events. We discarded, because of improper temperatures, about 4,000 pounds of food during the special event season, and $19,000. So this value is provided by the person in charge. So we are gonna discard a gallon of milk. If they tell me that's $10, then we have to write $10 because I think they claim it on their insurance or business laws. So sometimes that number is kind of increased because they want to claim the insurance. Next slide. So we also work with emergency preparedness. We inspected the DNC before the DNC started, and during the DNC, we had training for our staff, training for the venues. We did assessment of the facilities. We had to do several walkthroughs of the venues during the prior to the event and during the event. We had inspectors there from 5 in the morning till 11 p.m. Because they were prepping food before the event. We had to be there during the event and at the end of the event to make sure they're sanitizing and they're finishing up for the day. So we discarded about 400 pounds of food during the event, and one of this was like 300 pounds of food that was arriving at one of the Navy piers, because we were doing continuous monitoring with FDA. We worked in Unified Command with the FDA. But like this truck that arrived with the food, we didn't know where the truck was coming from. They didn't tell us they were arriving, and it was out of temperature. So since we didn't do continuous monitoring for that one, like about 1,000 portions of chicken could not be served for the delegates at one of the events. Next slide. So here are our challenges: staffing, retention, hiring, vacancies. It's hard to for retention because this is a difficult job. They have to be in the communities. And it's now the public is a little bit, sometimes they get difficult, and some sanitarians is just too much for them. They have to deal with a lot of challenging operators. One of the challenges that we've had also, like Dr. Ige says, we don't have enough coverage. So we have not inspected Chicago Park District events or reviewed them. So that's because due to staffing. And then
I just want to appreciate this team. They don't get a lot of visibility. They don't get a lot of acknowledgement, and they do a ton of work. During DNC, it was 4 a.m. to 12 midnight shifts. And people don't always appreciate what goes into this work. And we had to pull some people from DNC because it becomes confrontational. They have to go into people's spaces. They get confronted. We have to call in PD to protect them sometimes. So it is such hard work. I just wanted them to, before the year ends, just come before you so that together we can say thank you for all you do. Virginia, emails every day. So I just very appreciative of what they do.
And then our deputy is gonna review our initiative.
So, I mean, it's a great team. It's a committed, a lot of the sanitarians, supervising sanitarians have been worked with the program for many, many years. It's a team that never teleworked. Even during the mandatory shutdown, we were out there inspecting because people were ordering out. We were only able to work from home, maybe not even work from home, to go home, do the reporting, come back and post it. But by law, we have to do the inspection, give the operator the results right there. So Virginia's leadership throughout these past years have been, tremendous. We do have challenges. We are trying to work things, out. We are pretty ambitious with some of our initiatives that we have planned for 2025. We are working on upgrading our inspection software. So right now we do our inspections electronically through a software application that is no longer supported by that vendor. So we had to go and acquire a new application. Right now that contract is being reviewed by the Department of Law, and hopefully we can shepherd that through and get started and hopefully have something by midsummer. The other goal is to also, and this is not, we can talk about health code enforcement, but that's another regulatory function that we have. So to get those scanning and body art inspections, because those are actually done on paper, onto this new application. We're also working on streamlining our process for special events. So Virginia mentioned we reviewed like 500 special events, we issued license. We have to collect and review all that information. So there's a lot of paperwork that comes in, a lot of documentation. And we're going to be working on streamlining that process and working with the ACP as well to make sure that we're efficient, that we are able to give that operator the go ahead, like, yes, you can participate in the event. Unfortunately, sometimes we're giving the okay, like literally like 2 days before the event, but because we are so short staffed and we are piecemealing things together, it takes time for us to review the events. We're updating our website, we're developing, checklists. And the goal is to provide information and be transparent so the operator can go on our website, pull those checklists and say, oh, I'm going to be applying for this license. This is what I need. This is the information that I need. We last year went out into a community ward and we were hoping to do this more often in 2024, but unfortunately we don't have the time. So we went out to the next year, invited leaders to come. We says of like when you come, this is what you can expect. Presentation comes online. And then one of the other things we're going to embark is doing a quality improvement. We have to raise you're able to see Thank you. Thank you. Thank you. We are basically
But I think, today's theme really highlights, I think, the importance of public health. I think so often and I actually appreciate it. I remember food inspection was actually presented. It's always, it's a very interesting topic to hear about. But I think you really lifting your day to day. That's what everybody, all Chicagoans interact with, and that's kind of what I think is important to calibrate the needs that are really important to the city. And not necessarily just respond to press. And what's out there in the media to include like the vaccine. But really appreciate it. I wanted to actually say the word comments to be part of it. I wanted to actually share with everybody. I know the mayor's office is already aware. Dr. Ige, we've actually had many conversations in the team plans to be stepping down here. So, currently, it's a good transition time. And I agree that we'll continue to focus on how to improve access to greater healthcare, but really focusing on some really exciting things that I will be working to. A huge kind of the South Side. Really focusing on community-centered, comprehensive care plans for chronic conditions. Explicitly that, but I really wanted to make sure that any type of transition moving forward, we expect it as it should. There should be new blood that comes in, that whatever transition is smooth, and I am committed to assisting in that in whatever way, in whatever capacity might be required. But it really has been a privilege. I think usually this calling just comes because someone taps me on the shoulder, and I'm actually very appreciative that someone actually from CDPH tapped me on the shoulder to actually even think about serving. So I'm very much appreciative being able to work and be played in the past 4 years, a great kind of foundation in terms of how do we actually continue and promote the dialogue to ensure that public health is actually a core service and actually a component of really thinking about the health and livable place of the city. So I intend to stay in touch with everyone. And please don't feel shy about reaching out to me as well, because I really appreciate it. I know I said that previously I worked at CPH. I really want to say thank you. And with that, we have no public comments. Okay, we have no new business. We have no old business, and we will adjourn.
Good night. Thank you so much.